Я хочу сказать по-русски, что большое спасибо за приглашение в Ярославль. Это большая честь для меня. But I cannot speak longer Russian, so sorry for that. Okay, so I want to present you a very special study because the topic of this study is completely different than the previous studies. This is the real life study, which means that patients recruited for the study were consecutive patients coming for colonoscopy, and they were not selected. So this is the real data. Nobody was excluded, and those who wanted to have colonoscopy were included. And the second unusual and special thing is that in this study we were aiming to assess whether patients drank enough water after drinking the drug. So the main purpose was to check compliance to drinking water. This is very unusual study then, and we checked that using a special questionnaire. Patient just ticked every 100 milliliters on the questionnaire whether they drank or not. So this is for safety reasons. It was required to check this, and this study I want to present to you. And we discussed already how it is important to have a good compliance to drug and to water to increase efficacy of cleansing and safety of procedure. And our study was done, this is also something unusual, in 4 European countries. So this is not a single center, this is not a single country, but it's a multi-country study which gives another strength to this study. Of course, we discussed it a lot today. We need clear instructions to have a good compliance. We need a clear instructions. In our case, you discussed whether this should be explained by doctor or by personnel. In our case, this is a task for doctor to say only 1 or 2 sentences, that this is very important to be prepared well. And then the details are given by the personnel. Because it's surprising, a lot of patients do not understand why they drink this preparation. They think it's maybe necessary for, I don't know, to prepare something, but they do not understand that it's about having a clean colon. And if we explain that, then they follow instructions better. Of course, the split dosing rule is the best. We know the taste and smell, and to avoid vomiting, I think, and also nausea, this is very important to drink slowly. And the patients should be informed that they should not rush. It should be very slowly, small drips of water and aceclane or other bowel preparations, and it diminishes the risk of having nausea and vomiting. They should know it. And it's also better when the solution is cold. So it's kept in the freezer, and it's usually nicer and easier to avoid vomiting and nausea. And I think it's not real vomiting. We discussed that. This is just vomiting some content of the stomach, and it's not the food or whatever. It's different than the typical vomiting. It's just nausea. A strong nausea is sometimes defined by patients as vomiting, which is not the true one. Okay, we discussed the split dose already. I don't need to repeat that. But there are also some aspects that have to be discussed with the patients. First, we discussed already that once in a lifetime you have to wake up early, and this is acceptable. And the patients should be aware, because majority of colonoscopies are performed as outpatient, so the patient have the way to the center. So on the way to the center, sometimes there will be a problem with the toilet. So they have to prepare for that, and they have to know what to do in case they really require the toilet. Most often it's not a problem, but sometimes they have to be prepared. Otherwise, they will have dirty things and so on. So sometimes it's very important after the morning dose to be able to know where to go to the toilet on the way. And you already discussed with the anesthesiologist this issue of timing between the last dose and the beginning of colonoscopy. In our case, the optimal timing is 4 hours, although we know that it is allowed 2 hours before having the sedation. But anesthesiologists usually have problem with these 2 hours, and we know it's everywhere. Therefore, in our practice, 4 hours is the timing that it's more acceptable. And also for the bowel preparation, it's also optimal time to have these 4 hours. Now, in the era of many different drugs, we instruct all our doctors that in the colonoscopy report, they should put the name of the drug with which the patient was prepared. It's always not written. It was not always written in the colonoscopy reports. And I think it is important because next time patients do not remember what they used, and it's important to have the information what was the bowel preparation drug. And also, it's now obligatory, and I think everybody is assessing the quality of bowel preparation. We use Boston scale. But I want to say you one paradox. You discussed the adenoma detection rate and bowel preparation relation. But our observation is that good endoscopists have worse bowel preparation patients. This is because a good colonoscopist who has a high adenoma detection rate would like to have a perfect bowel preparation, and his own scale is different. So you can recognize also a good endoscopist by having a small fraction of perfectly prepared patients, because they want to be perfect in everything, in detecting polyps, in removing polyps, but also they want to have a perfect bowel preparation. So this is paradox, and that's why it's not so easy to prove that the better bowel prep means higher adenoma detection rate, because those who have a higher adenoma detection rate, they rate the bowel preparation as lower. So that's why this is the paradox. We should remember about it. Okay, we have already seen this drug that we discussed, and now let me go to the study itself. So the primary aim of this study was to study the use or misuse in a way that that we wanted to know whether there is an insufficient liquid intake. And in a real life setting in the European population. We also wanted, as a secondary aims, were the safety profile. Of course, we checked the adverse events, and also another unique of this study was there were special populations. So we were concentrated on having older patients and those with the higher risk of electrolyte shifts. So these patients were required to be in a special proportion, and I will show you that this special population is represented well in this study. So we had 1,200 patients, half by half male and female. The age was 60 years, BMI 26, and the indications, majority of these patients were screening, colonoscopy. In countries like Germany and in Poland, we have primary screening colonoscopy. That's why there is so many patients for screening. The other indications were polyps, rectal bleeding, other gastrointestinal disorders. And these special populations, we had in this group 40% of patients that were 65 years old or more. So this is large group of patients with the age that could have more adverse events. There were some patients with the suspicion of liver disease, some patients with already hyperuricemia, with some small number of patients with renal insufficiency and some patients with inflammatory bowel disease, because these were the consecutive patients. One by one were recruited. Majority, of course, used split dose, but it was just a routine recommendation. We have not recommended anything because of the study, but we just were observing what was indicated by the doctors. And the definition of non-compliance was if you drank less than those 4 cups of water. So as you know perfectly, I know the instruction. The patient uses the Esiclen, then adds water, and then you have to drink additional 2 cups of clear water after first dose, and additional 2 cups of which each of it is half a liter of water. So compliance could be 100 when the patient drank all 4 cups, or 75% if there was only 3 of those or less. So this was the definition of the compliance for these patients. So as you can see, in a real life setting, 86% used 100% of the water that were intended. So I think this is a great information, because majority used drink all the water. And full compliance, meaning more than 75% up to 100, was 95% together, these 2 first rows. So majority really were compliant, which means more than 3 cups out of 4 of water they were able to drink. Only minority of patients had some problems with drinking, and they were just defined as non-compliant, and this was 5% only. We also checked compliance to the drug, to Esiclen, and there was the question was whether they drank both bottles of Esiclen, and the compliance was also very good. 96% of the patients were able to drink all was intended. The quality of bowel preparation in this real life setting was 87% of having very good or good bowel preparation. So this is in comparison to the previous studies, maybe slightly lower than in the randomized control trials, where there is a special assessment. This was the real life assessment. The endoscopists were not really aware that they are the part of the study in most of the cases. So the contacts with the patients were by the different doctors than colonoscopists. So the colonoscopists were not involved in talking to the patients. So that's why this figure is reliable. So this is the real life data. And about the adverse events, there were the spectrum of adverse events were as expected, and there was nothing special to this population. Majority of the adverse events were of mild intensity, and there were most often it was nausea, and despite we were instructing the patients to drink slowly, there was some nausea. It was 14%, and vomiting was only 3%. It happened. It was not 10%, but much less, and other adverse events. So, in summary, in this real life study, multi-center European study, we could show. We could answer the question that 95% of patients are able to drink the water that is intended after drinking Esiclen. And this is important for the safety of the patients, because if you drink only the drug and not water, first of all, you will not be prepared well, but then there is a safety problem that dehydration could happen, which could be dangerous for the patient. So That's why it's important to drink all the water. And it turned out that 95% of patients were able to drink all the water, and the hydration was excellent. Also, 96% of patients were compliant to drinking Esiclen, and bowel cleansing were excellent or good in 87% of patients, which in real life is a very good figure. Esiclen was well tolerated, and safety profile was similar to previous reports. And this large study has proven that the efficacy and safety is excellent for this drug. So there is no worries about it. So overall summary, to achieve excellent bowel preparation, it is always necessary to follow general rules. Drug is not enough. The general rules are important: split dosing, information, motivation, and timing as general rules are very important. And randomized control trials confirmed excellent efficacy of Esiclen as a bowel preparation drug. And this, our study, the real one, confirms the real life excellent compliance to the drug and to the water. So hydration or dehydration is not a problem, it's not a risk. Hydration is enough, and we are happy to prove that this works in the European study. And these are the studies, the countries. It was Netherlands, Germany, Poland, and Czech Republic. And these are the names of the investigators. Thank you very much for your attention.
Большое спасибо, Ярослав, за очень интересные данные. Они, может быть, еще в какой-то мере более ценные, потому что это отражение применения препарата в реальной жизни. Если есть вопросы, которые... Да, пожалуйста.
Да, есть вопрос. Кострома, госпиталь ветеранов войн. На базе нашего учреждения развернут гериатрический центр области. Соответственно, мои пациенты в основном 75+. Для колоноскопии возраст есть и 90-летние. Естественно, пробовали подготовку различными препаратами, но есть процент большой, что приходится готовить заново. Вопрос следующего характера. Какой вы считаете оптимальный период для повторной попытки колоноскопии и какой минимальный период, чтобы у пациента не было осложнений, с учетом их большого количества сопутствующей патологии?
Yeah, the first question is why they were not prepared first time. And I think the problem is the instruction or help with the bowel preparation in older people. If they drink enough and if they drink drug and the water, they should be prepared irrespective of the age and comorbidities. This is the first. I understand that people with different diseases or older should always be prepared in the hospital, not as outpatient, because of the instruction problem and also because of keeping all the rules. And the other diseases, for example, diabetes that was asked today, you need to give some intravenous fluids. You have to control the glucose levels, and you need to stop, let's say, the usual dosage of insulin or whatever. So you have to adjust. So it can be only done in the hospital. But despite all that, but I think in the first place you should follow all the rules, and the patients will be prepared only once it should be problem. If it happens that it's not prepared, our practice is to repeat the same next day. So we do not discharge the patient for home and then invite again a month later or whatever. We continue with the preparation. We repeat the dosage, and the next day there is a colonoscopy. So I don't think there is any problem with repeating the same, because if patients drinks enough water and the drug, there should be no electrolyte shifts, and it's the same for trans. So there is no, in my opinion, risk of repeating every day again the bowel preparation. And in our practice we do that. I don't know how Thierry, yeah?
Я из Ярославля. И мне вдвойне приятнее задать вопрос человеку по имени Ярослав. Профессор Я.Регула, мой вопрос чисто практический. Вы показали в своем выступлении инструкции по применению изиклена, в которых написано, что мы можем его использовать в двух вариациях. Мы можем назначить пациенту изиклен вечером накануне исследования, и мы можем использовать сплит-дозу, когда изиклен применяется вечером и утром в день исследования. Однако в России ситуация, что многие врачи работают в частной практике и выполняют колоноскопию во второй половине дня, после 15 часов. Каким образом оптимизировать, каким образом использовать изиклен, когда должна быть принята вторая доза изиклена, чтобы проводить колоноскопию время после 15 часов дня? Какие ваши рекомендации по этому поводу?
So in that case, we also do a lot of colonoscopies in the afternoon, after 5 o'clock and later until 8 o'clock. So for these patients, we calculate the time from the back. So if we know that the timing of the colonoscopy is 6 o'clock in the evening, we instruct the patients that he should stop drinking 4 hours before, which makes 2 o'clock? Yes, 2 o'clock. So at 2 o'clock should be the end of the second dose. Then if you calculate the patient drinks usually all the portion within 2 hours, then it's within 2 hours. So then we instruct them to have two choices. One is less convenient, to drink first dose the day before in the evening and the second at 2 o'clock on the day of examination, which makes preparation very long. But the other option is to do the same day. You start at 8 o'clock or 7 o'clock, and then you have a break of 2-3 hours, and you then have a second dose finishing at 2 o'clock, especially if it's in sedation. If it's without sedation, we can say also 3-4 hours before colonoscopy. So the same day preparation is also recommended in the older ESGE guidelines from 2013. I don't know how is that in the current guidelines, and it is applied for, I think, all the drugs that are for bowel preparation, and I don't think there is any risk with preparing with Aziclan or Fortrans on the same day, but you have to calculate the timing from the back and instruct what the patient should do exactly.
Можно я все-таки еще раз уточню? То есть возможно использовать изиклен в однократном применении утром в день исследования. Это допустимо?
You mean both doses and all waters without the break? No. With the break?
In the morning of the day, утром в день исследования.
Yeah, of course, yes. Yes, but it should be tried to, if it's in the afternoon, the colonoscopy is in the afternoon, you can do the same day dosing, and I don't think any risk connected with that, but it's the full bowel preparation should be followed, and it's better to have it in two portions with some break of drinking, which is helpful for the patients. It makes it easier.
У меня очень короткий вопрос, он касается осложнений, нежелательных явлений, которые были описаны в исследовании. Там 2 тяжелых осложнения каких-то. Вот думаю, для аудитории было бы интересно, что же конкретно случилось у этих 2 людей из 1200. Спасибо.
Okay. In fact, there was one death in the patients. It was in the patient with hepatic insufficiency, and it was regarded that the death was not related to the bowel prep, and the patient was severely ill and was included into the study, and this was this side effect. And the second serious, I'm not sure if I well remember. I remember this case, of course. This was important, but it was, as you know, we grade all adverse events as related or possibly, probably, or non-related, and it was definitely unrelated to the drug preparation. So it was real study, and maybe this patient should not be included into the should probably not have the colonoscopy at all, but he was in the study. I will check what was the second. All right. You remember? Yeah, maybe you can answer the question. Yes, here.
So one patient had hepatic insufficiency, but actually she had ovarian cancer to begin with, so she should not have been included.
Yeah.
Another patient came to the hospital twice with alcohol intoxication. Oh, one patient had ovarian cancer and should not have been included under the patient you mentioned, and she died. And the other patient came to the hospital with alcohol intoxication twice. So she came to the hospital, was alcoholic, and
Yeah, I agree.
yeah.
So as you see, the real life study shows the cases where it happens that someone is in alcoholic intoxication and you give the drug. No, so I think it's unrelated to the drug, both these complications.
Yaroslav, thank you very much once more.